On this month's EM Quick Hits, as part of our Best of University of Toronto series, we have a special guest, the Chief of the ED at North York General Hospital, where I work, Dr. Kevin Wasco. Welcome to EM Cases, Dr. Wasco.
Thank you, Anton. It's great to be here.
All right, I'm not going to give away the topic up front. Instead, let's just present a quick case. It's 4 a.m. on a Saturday night at rural Janus General, and an otherwise healthy 32-year-old woman comes in, and she's day 13 post uncomplicated tonsillectomy for recurrent tonsillitis with peritonsillar abscess. She tells you that she woke up at 11:30 p.m. coughing up a bit of blood. She feels a constant trickling of blood down the back of her throat since then. On exam, her vitals are normal except for a heart rate of 115, and when you take a look at her pharynx, you see exactly what she described, a trickling of bright red blood from the left tonsillar fossa. So we have a young, healthy woman with about 5 hours of constant post-op tonsillar fossa bleeding, and we're 3 hours by road to a hospital that has an ENT on call. So first, Dr. Wasco, let's talk about why these patients bleed. This patient is 2 weeks post-tonsillectomy. Most of the bleeds I've seen have been within the first day or so. Why do these patients bleed at these different times? When should we be thinking about patients bleeding after having a tonsillectomy?
So there's two classifications of post-tonsillectomy bleeds. They're the primary bleeds that occur in 24 hours or less, and they are generally bleeds that are occurring because something happened intraoperatively, or they may have an undiagnosed coagulopathy. And then there are those in the secondary bleed classification that occur after 24 hours, usually up to 14 days. And they're generally in the 5 to 7 post-op days. These occur because the fibrin clot has been sloughed off and it's exposed the tissues underneath, and bleeding occurs. Oftentimes they start as a trickling bleed, but they can be very brisk and they can be massive bleeds. And so I think the most important thing to realize is that even though some bleeds start as a trickle, they can be a herald bleed and turn into a massive bleed. Also, if a bleed has persisted for this many hours, even if it is a trickle, it may be unlikely to stop just with the temporizing measures and would need definitive care from an ear, nose, and throat surgeon.
Okay. So suffice to say that pretty much all of these patients are going to need definitive care with ENT. So getting ENT involved early is always a good idea. Don't delay that call to ENT. All right, so you're 3 hours away from an ENT surgeon. What are your treatment options at 4 a.m. on a Saturday night? What are you going to do for this patient?
So for these patients, I think they need to be approached in a 3-prong approach. First is focus on resuscitation. Second is getting help, getting them transported early. And number 3 is temporizing measures that really just buy you time and hopefully slow or stop the bleeding while you're awaiting transport. In terms of the temporizing measures, there are many options. So your options for temporizing measures include direct pressure, topical agents, and TXA that can be provided in a number of different ways.
So I love that 3-pronged approach. There's resuscitation, there's making sure you get help early because, again, these patients need definitive care regardless of whether you can temporarily stop the bleeding or not, and the temporizing measures. And we'll get into all of these in just a minute. So what did you do in this case?
So first things first, I went in the room, made sure that the patient was in a seated position and a position of comfort so that I was able to get a good look and identify where the bleeding was coming from and how briskly the bleeding was happening. I did initiate a call to the tertiary center to an ear, nose, and throat surgeon so that we could get transport arranged and that was in the works as I then moved to the next steps to try to address the bleeding. The first thing that I did was apply direct pressure. And I did this almost instinctively by just putting gauze back against the spot of the bleeding on the tonsil and that didn't go well. I needed to regroup and see how I was going to approach this in a better way. I used topical lidocaine spray, and then I actually used gauze soaked in lidocaine with epinephrine and applied direct pressure. At the same time, the nurses were obtaining IV access, and we gave IV TXA. We also gave IV ondansetron because the last thing that I wanted was the patient to be vomiting, particularly as I was poking around in the back of their throat and causing their gag reflex to kick in. I gave nebulized TXA while I was preparing my airway materials in case I would need to intubate. I found that that was an easy intervention that I could just put on the patient, that I was doing something active while it still freed me up to prepare for the next steps.
All right. Yeah, I want to talk a little bit more about TXA. So you've got nebulized TXA, you've got local topical TXA, and you've got IV TXA. None of these have great evidence, but there have been some reports, case series, and small studies. How do you suggest we think about which one of these to use or which combination of these to use in these cases?
So one of the most important things that we can do is apply direct pressure, and we're going to apply direct pressure anyway. So soaking that gauze in TXA and then applying pressure is an easy thing to do, and I think that that would be probably the first place that you could use TXA. As I said, I gave nebulized TXA because it was something that I could just put on and then get other aspects ready, and I think that that's something to consider as an active process that isn't actively taking up your time. And then the IV TXA can be given by nursing and a task that's delegated to someone else in the resuscitation team. Again, all of these are lacking in evidence in this indication, but there's no evidence to suggest that they're harmful for this reason. And there are small studies, particularly in the nebulized TXA, that are being done and showing promise.
Let's step up the case a bit and say that the patient starts to gag on the blood and looks like they're aspirating, and then they start desatting and they're tiring, and you decide that you need to intubate to protect the airway. What's your airway strategy going to be? And what else are you going to add to your management?
First thing, call for help if you have someone that is at your disposal to call, whether it's anesthesia colleague or a second physician. I know for many of us who worked in rural places, that's not a luxury that we have, but if you have it, call. These can be very messy airways. They are not necessarily technically difficult from an anatomical perspective. So it's important to have adequate suction, whether you're using a decanto suction, a meconium aspirator. There's a lot of approaches that have been outlined in the Massive Hemoptysis EM Cases podcast that could be used in this case. And really, suction is so important. So having the suction available, clearing the airway from the bleeding as much as possible so that you can have a good look with video laryngoscopy, and then taking an RSI approach, which is what we're all used to.
Great. And then in terms of what you're going to order for blood work, what other things you're thinking about in the back of your head? Like, could this be a bleeding disorder? What else are you going to be doing before this patient gets transferred to ENT?
Yeah, so in terms of labs, getting a hemoglobin level, knowing where they're sitting, getting a group and screen. If it's been a massive bleed, maybe cross-matching blood. If they're on anticoagulants, giving prothrombin complex, getting a fibrinogen level, are all things that you're thinking about depending on the patient. Those labs will be wanted by your center where you're sending the patient as well. So getting them drawn off, even if they're not going to be back by the time the patient's still in your care. And then in terms of thinking of what this could be in terms of an unidentified coagulopathy, particularly in your younger patients, it should be something that's in the back of your head. And in those patients, you could consider giving IV DDAVP.
All right, and that would be for an undiagnosed von Willebrand's, I'm assuming.
Yes, that's right.
Okay. So yeah, a lot of these kids, 7, 8, 9, 10-year-olds will come in and they have undiagnosed von Willebrand's. And if they're really bleeding more than you'd expect, that's something you should think in the back of your head and consider giving one dose of DDAVP, which doesn't have much of a downside either and could be life-saving. All right. So how did the patient do in the end?
So the patient eventually did go out by air ambulance to the tertiary center. The patient was not bleeding at the time of transport and did not bleed in transport, which I was glad to hear afterwards. They were seen immediately by an ear, nose, and throat surgeon at the tertiary center. A large clot was identified, removed, and the patient was cauterized in the operating room. And so in the end, all ended well.
Fantastic. All right, let's bring it all home with some key take-home points then. So first, to understand that there's primary and secondary post-tonsillectomy bleeds. The primary ones happen in the first 24 hours or so. And for those ones, you should be thinking about maybe an underlying bleeding disorder. And those ones are often because of intraoperative factors. And then the secondary bleeds that happen after 24 hours, typically around 5 to 7 days, but can be up to 2 weeks. Those ones are because of the clot that comes off. They can be little trickling bleeds that don't look bad. But again, one of the key points is to get your ENT surgeon on the phone early, because pretty much all of these patients are going to need definitive source control, even if the bleeding settles down in the emergency department. We can break the approach to these patients down in 3 prongs. There's the resuscitation, there's getting your help early from ENT, and there's the temporizing measures. In terms of resuscitation, don't forget to position the patient sitting upright in the position of comfort, and that we're going to apply pretty much the same airway strategy as we do in the massive hemoptysis patient. It's RSI with video, and suctioning is key, preferably with a decanto catheter or a meconium aspirator setup. For temporizing measures, you want to apply direct pressure, and your medication options are TXA and epinephrine. TXA can be given nebulized. It can be soaked in gauze and applied directly to the bleed, or it can be given IV. And you might want to throw on the nebulizer as you're getting everything else ready. And just like any life-threatening bleed, if there's DOACs on board, you're considering PCCs and vitamin K. You might be giving red cells, particularly if your patient has, like a shock index of more than 1. And don't forget to get that fibrinogen level if you can get it, because later on, if the bleeding is massive, they may require fibrinogen concentrate. And one bonus little clinical pearl, for topical application of meds and for trying to apply gauze to the area of bleeding, one thing I found useful is using one of those see-through plastic vaginal speculums with a light built into it, because that gives you great exposure, it gives you great lighting, and it gives you great access just to that point of maximal bleeding, rather than putting a headlamp on and trying to get the patient to open their mouth. And it's a nice little trick that can be used for these patients. Any other last words of wisdom you want to leave our listeners with, Dr. Wasko?
I think just really emphasizing that all of the things that we give are really temporizing measures, and what we need to equally focus on is trying to get these patients to definitive care, which is to, in some cases, tertiary center and getting transport arranged. All of the efforts that we put in to stop bleeding are not necessarily going to fix the patient. They're just going to buy them time until they can get to where they need to be.